Hi everyone, and welcome to the first video of our new series, Alumni Matters, in which we'll be chatting to several alumni and learning more about their careers, their thoughts on some of the key challenges our world is facing, and discovering how they are helping to shape it into a healthier, fairer and greener place. My name is Megan Meyer, Alumni Communications Officer at the University of Exeter, and today we're joined by alumnus Dr Tanimola Martins. He graduated in 2014 with a PhD in inequality in cancer diagnosis and currently works as a research fellow and lecturer in the Postgraduate Education at the University of Exeter Medical School. The 24th of September marks World Cancer Research Day, aiming to showcase the importance of awareness and commitment to cancer research and coming together to tackle this problem around the world. As such, we're delighted to be able to chat to him today about his work in this area. And thank you so much for joining us, Tani, and welcome.
Thank you very much, Megan. Hello, everyone. Wherever you are around the world, it's so good to be here.
So just to sort of give our alumni a bit more background to you and your area of work, what interests you about selecting the topic of your PhD study that you did here, and what were some of your key findings from that?
Wow, yeah, that's a £1 million question. The background, my interest in this study, we all have someone or know someone who's been diagnosed with cancer. So obviously, is a subject we are all interested in somehow. But my particular interest in studying cancer in ethnic minority, came about due to my own personal experience accessing GP. I had a minor health concern. I decided to approach my GP for help. But let's just say I didn't get anything that I wanted. And it took me about 3 more consultations at the GP before I got something. Now, mind you, I was still very new in the UK. The concept of the GP, I have no idea what it means. Back in Nigeria, where I'm from, when you have a problem, you go to the hospital. Everything is the hospital. So it was quite difficult for me to get what I wanted. Now, I have a background in clinical rehabilitation. The concern I had some idea about it. But still, despite my knowledge, I couldn't even access anything from the GP. Now, the second motivational well is when I started to engage in community groups. I was fortunate to attend this event where patients who had been diagnosed with different form of cancer were coming to, describe the ordeal of getting diagnosis in the UK and what you get from ethnic minority patients. In this case, I mean Asian and Black patient, where some sense of BGP delaying referring them to the hospital. Now, this kind of start to echo my recent experience at the time that, well, I had this problem as well. What is going on? Now, I don't know the immigration status of this patient who narrated their story, because your immigration status might impact on how you can access care in the UK. So those two things got me to start to think that, is it possible that when migrants come to the UK, many of whom might be healthy and may not have been to hospital at any point in their lifetime until this, innocuous thing starts. And so could this be that they will be having this sort of difficulty accessing care? And I don't think it's racist. I thought maybe there are other questions we should be asking. And this was why I got interested in this field. I came to Exeter for a job, and I just kept going on about ethnic inequalities during the interview. So Exeter being a nurturing environment, it wasn't a surprise a year later when my line manager, Professor Willie Hamilton, just said, well, Tani, would you like to do a PhD in that subject you're talking about? Of course, yes. I grabbed the opportunity, and the rest, as they say, is history, and I'm still doing that. At the time, my interest at the time is to determine whether there are inequalities in the pathways to diagnosis at all. Because I don't believe that healthcare, mind you, healthcare in the UK is universally accessible, it's free. So I don't expect, so I thought, let's just do this study and put this to bed. But well, 10 years on, I'm still researching. Since 2010 when these ideas came. So my key findings, we found that for some cancer types, ethnic minorities are more likely to delay seeking medical help when they have symptoms. Now, there are other research evidence showing that awareness is lower in this group. They are less likely to take up screening. But now my study, this systematic review at the time showed that they could be delaying presenting to their GP. A further study which I conducted during the PhD was a vignette-based study. This is like, setting hypothetical scenarios to patients. That, well, if you have the following symptoms, in this case, relating to prostate cancer, would you inform your GP about it? And if you do, and GP says, well, we want to do this test, digital rectal examination, where they put a finger at the bottom to feel the prostate gland, and PSA test, the blood test. What we found from that study is that for Black men, they may decline the test if they feel that their risk of cancer is incredibly low, say like 2%. Whereas when you look at white men, they would take the test even when the risk of cancer is 1%. So that was kind of informative for me that, well, these guys may delay presenting to a GP and they may decline test. And it is perfectly sound like a reasonable idea to decline when you think your risk is low. I don't have to have it. So, but further work has beyond my PhD has then shown that actually GP may be reluctant to offer some patient tests. In particular, Haitian men of Asian background may not be offered a blood test because they have other conditions at the time that may, make them have the symptoms of prostate cancer. So GPs also could be reluctant to offer tests. What we recently showed actually is that, well, these guys, they use healthcare more. They go to their GP more when they have possible symptoms of cancer. They may decline tests. GP may be reluctant to offer some of them certain tests for some reasons. But actually, we found that they, from Asian and Black background, may experience longer time to diagnosis when compared to white men or white patients. Happen across about 7 or so cancer types, that they have longer time to diagnosis. They're more likely to experience delay in cancer diagnosis, which was quite a big find, because when you go back to 2010, when I had this engagement with patients, this was what patients were saying. And it's just taking me up to 2022 before my research is showing that actually this is true.
That sounds like a real journey to have gone on throughout all of your research and personal experiences as well, and something that you wouldn't necessarily think, as well as having to deal with the difficulties of potentially having cancer, then facing all of the obstacles in terms of diagnosis and accessing care as well. My sort of follow-up question to that would be sort of how large a scale do you think this issue of ethnic inequality in sort of diagnosis of cancer is, and is there anything that could be done to sort of reduce that impact, that gap?
Regarding the question of how large issue is of ethnic inequalities, I think the short answer is we don't know. So recently, I say recently, say 2006 and now, that GPs are incentivized to collect data on ethnicity. We didn't used to collect ethnicity data. So it's getting better. So this is why we don't know this. We don't know the full extent of ethnic inequalities in health, because we need data. If you have the data, you can do the investigation and find out whether there is any inequality. So we don't know the full extent of ethnic inequalities in cancer, but we have some idea. And I dare say that we're actually lucky in the UK. In some European countries, they don't even collect ethnicity data as we speak. And it's not as if that inequalities in health across ethnic groups would exist, because as Europe becomes more ethnically diverse, all of these problems we'll start to notice them. So we have some idea of what is going on in the UK. A recent study published around early this year shows that for some cancer types, the Asian and Black group, particularly women, are more likely to have advanced stage diagnosis. of some cancer. I think this was in 5 of 7 cancer types that they looked at, indicative of potential outcome, because advanced stage diagnosis is associated with poorer survival. So we have the idea that, well, this is what we're seeing. And when you look at America, the African American, they have worse outcome for nearly all cancer types. So the UK picture is showing something similar. Minority groups may have advanced stage diagnosis. What we also, what we don't really know as well, and which is important, is why. Healthcare is free. Why? So when you look at American study, Americans have done quite a lot. I've been saying Americans because they've done quite a lot of study on ethnic inequalities in health. What you find there is that socioeconomic deprivation, often linked to health insurance status, plays a significant role in racial differences in health care or access or outcome in America. But our own healthcare doesn't require money. Access your GP. So we have some theory of what could be happening. Socioeconomic status actually may play a part when you think about somebody having shift work, or somebody, they have a large family, they are single parents, or they are immigrants in the UK. They've moved here for economic reasons. Their priority is to get money. And so when they have back pain, which may be an indication of prostate cancer in some sense, they may not take it seriously. And Mitri may explain why some people delay seeking help, because many cancer symptoms are non-specific. It could be cough, it could be back pain, it could be headache, in the case of brain tumor. So socioeconomic status can play a part in that way in the UK ethnic minority population. The type of job they have, their priority, to be economically more or financially more viable, and that might affect them seeking help when they have problems. The other way socioeconomic status can impact is when you look at GPs in areas with significant socioeconomic deprivation. They tend to have a very, very large list size. So they have more patients using services in those areas, which means that they may not have sufficient time, to actually listen to their patients. So all of these things come into play. But fear of cancer is significant. We all know how bad it is to have cancer. And so all of these may impact on how people use their healthcare. We have all of these theories not fully explored, not fully examined. We should be doing some work around this area to actually understand how these factors play. So we have all of these problems in our healthcare that is like one size fits all, almost designed for the elite educated. People who understand, you're more likely to get something than when you're not so sure and you're just wondering. That we have this system that assumes everybody knows how to use it. It might just be the case, and thinking about solution now, that we may have to revamp some of the way we currently practice some of our techniques in clinical practice. We have to maybe help our upcoming doctors understand that not every patient will be able to link their frequency of going to the loo to prostate cancer. In ethnic minority community, I can speak for you from the Nigerian perspective. Nobody talks about prostate cancer like it's a very religious community. People say, well, God forbid, I wouldn't have cancer. And when people have cancer, they sort of, it's hush, it's quiet. It dealt with it. They may not even tell their children. When you have a family history of it, your risk of having it is almost double. So to make this make sense, there will be patient factors that are, theoretically causing these inequalities we are seeing. Fear is one I mentioned. Differences in socioeconomic status, which can manifest in the type of job people do, where they live, which impacts on how GPs can, watch how much time GPs have for patients. Health literacy is critical. We haven't investigated all these aspects I'm talking about. We need to do some research to actually understand how the mechanism of how these things operate in reality. The consultation time, the one-size-fits-all healthcare system that we have our diagnostic test may not be as accurate as we think for some populations. So these are the theories that we're developing and hoping that we get some funding to explore these areas more.
So sort of following on from that, obviously it sounds like there's so many things that could be done in that area, and so much more that needs to be done in terms of research and funding and things to investigate. And I'm just sort of interested in sort of like, what does your regular and current work involve?
But my current work uses large data. In the past, I will go out and do surveys and qualitative interviews. So we're looking at patient electronic record and trying to map their journeys from the first time they present to their GP up to diagnosis. The other thing I do, I teach. So I'm one of the lecturers on the Masters of Public Health program. So I teach on a range of modules, from planetary health to behavior change. I have ambition of being a leader in this subject area to help put the evidence out there, to help GP get better at their job, help patients understand how to use their GP more, and maybe someday we can all conquer cancer.
That's definitely a very good aim, and that's something that would keep you motivating through all of the different things that you're part of, because as you said earlier, I think we all know someone who's been affected by cancer, and there is that fear that this is always going to be a problem that we have to face. What keeps you sort of motivated as you're sort of working on this really big, and sometimes I can imagine challenging and slightly depressing maybe area of work as well at times?
It is depressing because you would think that when you get the data, it's all going to be straightforward. But I keep going because I'm a Black. 1 in 4, 1 in 2, Black men get prostate cancer or die from it. It's just frightening. We're going to be in that age bracket they talk about. Even in our study, you see that patient, experiences longer time to diagnosis. What is going on? I really, really want to get to the bottom of this problem because I know cancer does not discriminate. So the health service should not discriminate. If everybody's going to get cancer, we should treat everybody and make sure they get what they want at the time and not having these disparities. So I want to get to the bottom of this problem as best as I can. And hopefully some very bright younger scientists coming behind and take this even forward and, get us going. Because as UK become more ethnically diverse, as I said earlier, what we've been shying away from will become our real reality, and we have to deal with it. If there's something we learned from COVID, it's that you just can't continue to ignore your neighbor.
I think that's something that we can all take forward, is that we're not doing anything in isolation, and like you say, cancer doesn't discriminate. We need to be helping every single person with it in the ways that we can. So for anyone that's been listening to our chat today and is interested in knowing how can we help or learn more or take this forward, obviously with sort of World Cancer Research Day, one of its aims is to increase awareness of cancer research that's taking place and the challenges, and all come together to really tackle them.
Email me directly. I'm always very, very happy to talk to people. If wherever they are, they want to organize awareness campaign or like a community kind of discourse on any type of cancer, I'm always willing to attend such event. What I also want to encourage people to do is to talk about cancer within their family, within their spaces. Don't leave it to the charities. We can't leave it to GPs. GPs are very, very busy, wonderful people. We as a family, if you know somebody in your lineage that have had any form of cancer, it's important to discuss this with your children. Let them know that, your grandparents had cancer. Just so people understand their own risk, of the disease. So let's talk about cancer more within the community. But we need this knowledge. If you have any symptom, go to your GP. Don't be afraid of it. Ask you want to know. Some people say ignorance is bliss. Well, no. In the case of cancer, it's a very, very difficult disease to manage.
Thank you so much for your time today, Tani, and for joining me. I really hope everyone has enjoyed watching and learning some more about this really important area. And as Tani mentions, there's lots of ways to find out more and keep talking about this as well. And we'll be doing more in our Alumni Matters video series, so keep your eyes peeled on our website and our socials for our next video launching later this autumn. Thank you so much, Tani.
Thank you.